Yeah. Good evening, everyone, and welcome to session 2 of Lupus Ontario Symposium, Cutaneous Lupus, More Than Skin Deep. My name is Priyanka Rossi Sebastian, and I'm a proud lupus warrior for over 6 years and a volunteer with Lupus Ontario's Education and Awareness Group. I'm honored to be part of this symposium, and I will be your host for this session. It's a pleasure to have you join us this evening. Before we begin, I would like to take a moment to thank Roche, our presenting sponsor for this year's Lupus Ontario Education Symposium. We are very grateful for the generous support, which helps make sessions like this possible. We'll have time to answer questions at the end of the presentation, so please feel free to submit them at any point using the Q&A function or the chat box. It's now my pleasure to introduce our speaker, Dr. Alison Billy. Dr. Billy is a dermatologist and physician scientist at the University of Michigan, where she is the Abigail and Leslie Wexner Emerging Scholar of the Taubman Medical Research Institute and an assistant professor of dermatology. She provides care for patients with a wide range of skin conditions and leads a research lab focused on understanding the immune and genetic factors that drive inflammatory and autoimmune skin diseases, including lupus. Her work has been published in top scientific journals and is supported by national and foundation funding. The skin is often the first place lupus shows itself, but the impact goes well beyond the surface. This interactive webinar will look at many ways lupus can affect the skin, from common rashes to more complex dermatologic conditions. We'll discuss the different types of cutaneous lupus, what drives them at the immune and genetic level, and how they connect to systemic lupus. You will also learn how dermatologists and rheumatologists work together to diagnose and treat these conditions, strategies for managing flares, and practical tips for protecting and caring for your skin. Please join me in welcoming Dr. Alison Billy to our virtual stage.
Hi, everyone. Is my audio coming through okay? Is
Yes,
my
ma'am.
audio good? Okay, great. All right. Thanks so much for the introduction, Priyanka. Tough act to follow with Dr. Wither there. Great talk. And thanks to Lupus Ontario for inviting me. So as Priyanka said, I'm a physician scientist at the University of Michigan. And in my general dermatology clinic, I care for people with lupus as well as a broad range of other skin diseases. And in my research lab, we study why the skin becomes inflamed in lupus. And we use both patient samples and laboratory models with the goal of discovering better, safer treatments. So before we get started, I just want to give a quick disclosure. I have no financial conflicts of interest related to this talk, and my research is funded by the National Institutes of Health and the Rheumatology Research Foundation. And as Priyanka mentioned, our session's called Cutaneous Lupus, More Than Skin Deep. And tonight we're going to be talking about how lupus affects the skin, and I'll go over what's happening in the immune system beneath the surface and some practical ways to protect the skin. And I'm hoping that this session will explain some of the science behind the disease and leave everyone feeling a little bit more optimistic about where research and care for skin lupus are heading. So I'm sure many of you have heard that the skin is the largest organ, but it's also our largest immune organ because it's where the outside world meets the body's defenses. And because of that, the skin is often the first place that lupus reveals itself. And this also means that lupus rashes can tell us important information about immune system dysfunction that occurs in lupus. And gaining this understanding can help us prevent and treat skin lupus flares. So we're going to be talking about what cutaneous lupus looks like, some of the major types, what drives it at the molecular level, and how this knowledge can translate into everyday care, both now and as our research is continuing to evolve. So starting right at the beginning, cutaneous, meaning of the skin. So cutaneous lupus erythematosus, or CLE, is how we refer to lupus when it affects the skin. And some people have just CLE alone as an isolated disease, while others have both CLE and systemic lupus erythematosus, or SLE. And among people with systemic lupus, about 70 or 80% will experience skin involvement at some point during the course of their disease. And this means that CLE is one of the most common manifestations of SLE. Now, I know that when people hear lupus, one of the first thing that often comes to mind is what we call this butterfly rash on the central face. That's involving, as you can see in the picture, the cheeks and sometimes also the bridge of the nose, but it characteristically spares these creases along the sides of the nostrils downward called the nasolabial folds, which can help it sometimes distinguish it from other diseases. I saw a question in the comments about rosacea, which is a distinct disease, and rosacea and things like seborrheic dermatitis, sort of a dandruff of the face, can affect this area. So these are some of the things that we look for in acute rashes that help us determine if it's lupus. But this butterfly rash is actually just one of the major types of skin lupus because skin lupus exists on a spectrum. And the butterfly rash is classified as acute CLE, but there's many other types of skin lupus, each of which has a different appearance. And importantly, they can mean different things for a patient's health. So for example, in the case of the butterfly rash of acute CLE, this rash typically does not leave behind permanent scarring, but the presence of this rash is a very strong signal that the person affected has SLE. And in fact, half of all patients who have SLE may develop a butterfly rash at some point in the course of their disease. So if a patient has just the butterfly rash on the face, we call that localized ACLE, but there's also a generalized form of ACLE that usually presents as a symmetric, widespread, can be very widespread rash. Often it involves the back of the hands, but it will characteristically spare the knuckles, which is one of the signs that helps us differentiate it from another autoimmune disease called dermatomyositis that otherwise can look similar on biopsy and sometimes in our clinical impression. And
Hi, Dr.
patients,
Billy. Sorry to interrupt. Do you
yeah,
mind just resharing your slides once more? I believe some people are having trouble like seeing
yeah,
them. Just sorry about that.
no problem. Let me, here, I can try sharing the whole screen. It may have the, does this look okay now?
On my end, it looks fine, but how was that for those in the audience?
No. Let's see. Uh, let me try stopping and restarting.
So those in the chat, make sure to double click the presentation and it should enlarge. Okay, I
Did we
believe
get
it's
it?
yeah, I believe it's good now. Everyone's saying it's good.
Awesome.
Okay,
Okay.
sorry about that.
Um, no, that's great. Thank you so much. Sorry, I didn't notice. I will, let's see, just really quickly. Okay, good. This is the only picture you guys missed. Butterfly rash. You may have heard of it. Um, and then, okay. So let me get back. There we go. Okay. So, but there's actually many other types of skin lupus. And, we're talking through the butterfly rash. I was mentioning that in patients who have a generalized form of ACLE, acute CLE, they typically also have inflammation of the internal organs, and even the rash itself can be severe and very dangerous in rare cases, presenting almost as like a burn-like full body rash. And patients with acute CLE usually exhibit photosensitivity, which is a phenomenon where the skin reacts more strongly to sunlight than usual. Even a small amount of sun, or sometimes even light coming through windows or light from certain types of light bulbs, can trigger redness, itching, or a lupus rash flare. Now, moving on to the next category, subacute cutaneous lupus, or SCLE, typically appears as a rash on the upper trunk and arms that can either consist of red scaly rings or red scaly bumps and plaques, as shown in this picture, that can look a little more like psoriasis. And this type of skin lupus can lead to skin discoloration, like light spots, which we call hypopigmentation. But like ACLE, it does not cause scarring. Now, SCLE is only sometimes associated with systemic lupus, but patients who have SCLE are typically extremely photosensitive. And tumid lupus, which is sometimes also called intermittent lupus, shows up as sort of these smooth, non-scaly pink bumps and plaques. And it also doesn't scar and is almost never associated with SLE, but affected patients do tend to show extreme photosensitivity, and nearly all patients with tumid lupus will develop new lesions after exposure to ultraviolet light. And then finally, we have chronic cutaneous lupus, and there are many, many different kinds up here in the bonus box, but I'm only showing pictures of the most common kind below, which is called discoid lupus, or DLE. And discoid lupus typically causes these scaly, discolored bumps and plaques. They can show prominent scarring and hair loss. And even though most people with discoid lupus do not have SLE, people with discoid lupus can still be very negatively affected by their disease because the plaques tend to occur on highly visible areas like the scalp and ears and face. But in some individuals with DLE, lesions can occur elsewhere on the body as well, typically in sun-exposed areas like the arms. And these patients who have skin lesions below the neck are more likely to have associated SLE. And among these different major types of CLE, patients with discoid lupus are felt to be relatively less photosensitive, but sunlight can still induce or worsen lesions in many patients. And in reality, you see that photosensitivity is a common feature of all of these types of CLE. And even patients who report that they don't notice photosensitivity will often show objective evidence of it if you test their skin in the laboratory using these specialized light emitting machines that we use for photoprovocation, provoking the skin with light. Now, I want to mention that multiple different rashes can occur in the same person at different times during the course of their disease, or even simultaneously in a patient. And patients who do have multiple different kinds of CLE are more likely to also have SLE. So just to switch gears a little bit, I'm going to tell you a story about a patient that I saw in dermatology clinic when I was still in residency. And this patient did give me permission to share her experience. And this woman came to our dermatology clinic asking for help treating an itchy rash on her face that you see here in the picture. That's my finger sticking in there. And she said that the rash showed up after she went to Hawaii and was swimming in the ocean. And she wondered whether swimming in the ocean somehow caused the rash. And she had seen multiple different dermatologists and been treated for acne with several different creams and antibiotic pills without any improvement. And so this had led her to seek a second opinion in our clinic. So the supervising dermatologist and I both really thought this looked like acne because it had these little acne-like bumps that we call comedones, which are sort of the blackheads and whiteheads of acne. And then these little pits you can see in the picture that can sometimes be caused by acne scarring. They're called ice pick scars. So we were like totally stumped as to why this rash wasn't responding to acne therapy. And we were considering starting a serious oral medication for acne called Accutane or isotretinoin for her. And so before we did that, we wanted to make absolutely sure of the diagnosis given her story. And so we asked her if she'd be willing to undergo a biopsy of the skin of her face. So cutting out a small piece of the skin and sending it to the lab. That's what this picture is from. And to our shock, it showed that she actually had a rare type of chronic cutaneous lupus called comedonic lupus or lupus comedonicus. And what I want to draw your attention to with this story was the fact that she gave us the clues when she told us the story of the rash. So first, the fact that the rash was itchy. A lot of chronic cutaneous lupus is itchy. And in fact, itch can be a big driver of morbidity of the disease, whereas it's very rare for acne to be itchy. And then second, she was linking the rash to swimming in the Hawaiian Ocean, but it might have actually been swimming with the Hawaiian sunlight on her that she was exposed to that triggered this lupus rash. And then the third clue was that her suspected acne was not responding to typical treatment, which should always make us reconsider the diagnosis. And this example illustrates how we as dermatologists have to be humble and always be thinking about lupus. And the wild thing about this case is that before she came to us, she had had a biopsy at another clinic that reportedly showed lupus, and we still couldn't wrap our minds around this diagnosis because of how uncommon some of these presentations are. And unfortunately, the microscope slides from the original biopsy were inaccessible, so she agreed to undergo biopsy again so that we could try to help her. And I'm sharing this story because I personally learned a lot from this patient about how challenging lupus is to recognize. And I'm even more grateful to her because she subsequently came as a teaching patient to we have these statewide educational conferences where patients with rare diseases that we need to learn about come to be examined in person by over 100 academic and private practice dermatologists in the state of Michigan to help us improve our ability to diagnose and treat these conditions. And, we felt, and she agreed, that this type of lupus deserved more widespread recognition. And for each patient like her, there are hundreds of others with rare CLE subtypes that we're continuing to learn from so that we can have a better understanding of the spectrum of this challenging disease and be better partners in lupus care. Okay, so I am sure, or I hope, that I do not have to work too hard to convince this audience that skin lupus matters, but I do want to take a moment to impress upon everyone that these rashes can be much more than just a cosmetic problem. As I mentioned, the rashes can be itchy, they can be painful, they can cause permanent scarring and really negatively impact self-esteem. And because of this, lupus skin flares can significantly impair quality of life and raise rates of unemployment and double the cost of healthcare for patients with lupus. Skin lupus is a really, big part of the lupus problem. And unfortunately, skin disease and lupus can be very difficult to treat. For example, hydroxychloroquine or Plaquenil, which is a mainstay of lupus therapy, only effectively treats skin disease in about half of patients. And so before we get into treatment, I do want to take some time to talk about the significance of the skin to systemic lupus. And specifically, I want to talk about the growing evidence suggesting that skin inflammation could itself potentially feed into SLE, worsen SLE. I think Dr. Wither was referring to this in her talk briefly. So there's a few published reports of patients experiencing SLE flares after exposure to ultraviolet light while sunbathing. And in this report, a patient who had pre-existing mild SLE temporarily developed a condition called myelitis, which is where the spinal cord is affected by lupus-related inflammation and can result in neurologic symptoms like numbness. And in this patient's case, it happened on 2 different occasions. She developed this myelitis, each occurring 1 week after she reported sunbathing while on vacation. And then this is another case where a patient had been diagnosed with SLE previously, but she'd been in complete remission off all therapies for 8 years, and then went sunbathing in Turkey and got a sunburn. And then over the next 6 weeks, she developed this severe rash in sun-exposed areas. You can see the outline of her bathing suit, and was discovered when she was hospitalized to have lupus nephritis, which is one kind of lupus-related kidney damage, and this led to serious medical complications for her. And so we also have evidence from various kinds of lupus mouse models that skin inflammation may be able to promote SLE. And these mouse models have been used in lupus research, many of them for decades, and are extremely helpful for studying lupus because the mice tend to develop SLE-like disease in a very reliable pattern. So this allows us to study whether certain treatments or exposures can delay or accelerate development of specific disease manifestations or even death from disease. So this is one study that was published quite some time ago, back in 1985, and it showed that treating some of these lupus-prone mice with ultraviolet light sped up their development of autoimmune disease and caused them to die at an earlier age. But interestingly, it's not just ultraviolet light that can do this. So this study is from one of my colleagues and mentors at the University of Michigan, who's a rheumatologist named Michelle Kallenberg, whose research and clinical career focuses on studying CLE. She published a paper showing that even just injuring the outer layer of the skin, which is called the epidermis, in the mice by you shave them and then you repeatedly apply and pull off a piece of tape. It's enough to speed up development of lupus nephritis in lupus-prone mice. So these are just two examples, but there's many lines of evidence that the skin is connected to the rest of the immune system in lupus. But the details of the skin-body connection are still emerging. And what we know now is that the skin and the immune system are in constant communication. So when sunlight or infection or stress injures skin cells, they can send distress signals that can activate immune cells, not just in the skin, but throughout the body. And those signals and activated cells may travel in the bloodstream and potentially trigger joint or other organ inflammation. And in that way, the skin may not just reflect lupus, but could also potentially drive it. And our ongoing research in partnership with patients like you is helping us decipher these mechanisms further. But we're gonna, you guys may be used to metaphors, but we'll talk a little more with a metaphor about how inflammation happens in the skin. So for this, I want you to think of the immune system like a fire alarm. And when there's danger, like a virus, cells sound the alarm by releasing molecular signals, including a specific one we'll talk about today called interferons that Dr. Wither mentioned. And these molecules help the immune cells and other cells in the body fight back against dangers like viruses. But for the system to be effective, the alarm has to stay silent when there's no danger. And this balance is what defines the healthy immune system. Now, in contrast, as you know, lupus is a state in which the body's fire alarm is ringing in the absence of danger and it can't be turned off. And in the skin, this false alarm results in overproduction of interferon, which then drives chronic inflammation. And this excess interferon is actually one of the major causes of skin photosensitivity and rashes in lupus, which we'll be discussing in a minute. But first, we'll talk about several key cell types taking part in the immune conversation in the skin. So we have the keratinocytes, which are the main cell type in the epidermis, and they're important producers of danger signals, including not just interferons, but many other alarm type molecules as well. And next, certain kinds of immune cells called dendritic cells are able to detect these danger signals and amplify them, producing their own additional danger signals and also activating immune cells like B cells and T cells, who can then go out and cause more damage. So sometimes we talk about the keratinocyte skin cells as the frontline guards, and then dendritic cells, cell types as the sirens, and the B and T cells as the soldiers that join in. Now, in patients who have CLE, the keratinocyte skin cells are overproducing the interferon alarm signals at baseline. And this is even true when we look at totally normal, totally healthy appearing skin taken from sun-protected body sites like the buttock on patients who have cutaneous lupus elsewhere on their body. And from what our research tells us, this increased interferon production seems to be both genetically and epigenetically encoded in the skin cells of patients with CLE. And if you shine ultraviolet light on lupus keratinocytes, they also pump out way more interferon than healthy keratinocytes. And when keratinocytes live in this interferon-rich environment, they become reprogrammed to die more easily after exposure to sunlight, which is, again, a big contributor to the photosensitivity experienced by many patients with lupus. But interferon also promotes lupus in the skin in other ways. So one thing that we have looked at is that excess interferon disrupts the skin barrier, which makes it easier for pathogenic bacteria like Staph aureus bacteria to colonize the skin. And these bacteria then promote more inflammation by activating inflammatory gene expression in skin cells, resulting in a positive feedback loop. And our group actually recently published a small proof of concept study related to this, where we enrolled patients with active lupus skin lesions and randomized them to applying either Vaseline or topical antibiotic that targets staph bacteria for a week. And then we compared skin biopsies taken from the lesions both before and after treatment. And we found that lowering the amount of staph bacteria with the antibiotic helped normalize the expression of interferon-stimulated genes in the lupus skin lesions, and also decreased the overabundance of certain inflammatory cell types there. So targeting Staph aureus could someday help interrupt this positive feedback loop between interferon signaling and these problematic bacteria. And then interferons also may play a role in decreasing the number and function of certain immune cell types that would otherwise protect the skin from ultraviolet damage, called Langerhans cells and regulatory T cells. But there's another important thing interferon does, which is act upon the key immune cells that I was discussing earlier. And Dr. Kallenberg and I, together with a great team of collaborators at the University of Michigan, showed a few years ago that this high background level of interferon in lupus skin can actually teach certain siren cells to become more dangerous. So basically, the lupus keratinocytes are pumping out tons of interferon and other alarm signals that help recruit the siren cells from the blood into the skin. And then once they get there, the alarm signals reprogram them and cause gene expression changes in the siren cells that make them better at causing lupus inflammation and tissue damage. And then as for the soldiers, B cells are the ones responsible for making autoantibodies, like what the ANA test looks for. And autoantibodies can further instruct the immune system to attack the body's own cells. So, for example, many patients with SCLE, subacute cutaneous lupus, have anti-Rho antibodies that bind to a protein called Rho that's made by keratinocytes. And when keratinocytes are exposed to ultraviolet light, they transport the Rho protein to the cell surface where anti-Rho antibodies can find it and bind it and direct immune attack on keratinocytes. But not all patients with CLE have detectable autoantibodies on laboratory testing. In fact, many patients with discoid lupus don't. But despite that, skin biopsies of patients with discoid lupus show way more B cells than acute or subacute cutaneous lupus. So the relationship between CLE, B cells, and autoantibodies isn't perfectly straightforward. And then the role of T cells in skin lupus is also not totally clear. There's definitely increased T cells in skin affected by lupus rashes. But in collaboration with a rheumatologist named Deepak Rao and his group at Harvard, we found that the lupus rash T cells don't seem to be as activated as T cells from kidneys affected by lupus nephritis, suggesting that T cells may not be as important in driving cutaneous lupus as they are in damaging other internal organs in lupus. So to summarize, research from many lupus researchers shows that lupus keratinocytes overproduce the interferon alarm signal both at baseline and in response to triggers like sunlight. And this promotes photosensitivity, skin barrier dysfunction, and immune cell shifts. And the net result of this is that even skin that looks completely normal to patients and their dermatologists has baseline immune hyperactivation in patients with CLE. And these discoveries provide an explanation for why blocking interferon, such as with the medication anifrolumab, or also called Saphnelo, helps some patients with lupus and especially skin lupus. And what all this means is that the skin is an active participant in lupus, not just a target of the disease. So now I want to get into the more practical information, and we've spent all this time talking about how lupus skin is primed for inflammation, but we still need to understand the triggers that can flip that immune switch fully on and cause a lupus rash. And as I mentioned, ultraviolet light is the most common trigger, and sometimes even the short exposure can just set off the full cascade. But other triggers include infections, certain medications, stress, physical injuries, and hormonal changes. And if you're a patient with lupus, it's really frustrating to be told that stress is a trigger because, like I always tell my patients, I can't write a prescription for no more stress. So I try to encourage my patients to focus on the modifiable factors. And when it comes to those factors that they can't really modify, it can still be helpful for patients to recognize their own trigger patterns and act early to prevent progression and shorten the duration of their skin flares. So the single most effective strategy preventing and managing skin lupus is sun protection. And I recommend using SPF like 45, 50 or higher broad spectrum sunscreen daily, even indoor or near windows, because windows only generally filter out some of the UV light. And then reapply every 2 hours when you're outside, and wear UPF clothing. UPF is ultraviolet protective factor and is the clothing equivalent of SPF scores on sunscreen. Wide brim hats, very fashionable now, sunglasses, and then try to plan your outdoor time outside of peak UV hours. And now we have a lot of patients who focus mostly on sun avoidance, but don't wear daily sunscreen. And I do still try to encourage them to get in the habit of at least using a moisturizer with SPF, because even indoor lighting can trigger flares in patients with CLE. And that's because certain light bulbs, like compact fluorescent lamps and some energy efficient halogen bulbs, emit low levels of UV radiation, which in certain extremely photosensitive patients can be enough to cause skin redness and exacerbate their skin lupus, especially when the bulbs are in close proximity to the skin. So if you're looking for a safer alternative, LED bulbs do not emit significant amounts of UV radiation, and you could consider plugging those in instead. But I want to acknowledge that building all of these habits is a lot of work. You can think of them as daily medicine for your skin. And I want to stress that consistency is more important than perfection, because we are all human and we only have so much energy in the day. So when I talk to any of my patients about sun protection, I always tell them that I'm like thrilled with whatever they're already doing to try to protect their skin from the sun, but I'm still going to always challenge them to try incorporating one more thing before I next see them. But, inevitably, many of our patients do develop skin lupus. And when this happens, dermatologists turn to literature and treatment algorithms like this one to help select therapies for patients. And even though this is an algorithm, I want to stress that treatment is not by any means one size fits all. And we always try to engage in shared decision making with patients about therapies based on their specific CLE subtype, the severity of their disease, their other medical conditions, and their personal preferences. And we also make sure to discuss preventive measures, not just the sun protection that I keep harping on, but also lifestyle factors beyond the skin, and especially quitting or reducing cigarette smoking, which in addition to helping SLE, as you heard before, can also really make a difference in CLE, like decreasing the severity of skin lesions. And it can also make medications like hydroxychloroquine work better. Like in one study, smokers had a 40% response rate to hydroxychloroquine, and non-smokers had a 90% cutaneous lupus response rate. So it can make a huge difference. And then as for medical management, we can conceptualize the treatments in layers, and we're often using these layers in combination. So first, we have topical medications like corticosteroids or calcineurin inhibitors, such as medications like tacrolimus protopic, if you've heard of that. Those are applied directly to the rash to counteract the immune hyperactivation in the skin from outside the body. And in contrast, hydroxychloroquine helps quiet the immune system by working within the body. And then for tougher disease, we may add on other immune modulating or immunosuppressive medications like methotrexate or mycophenolate mofetil, Cellcept. And then more recently, we're reaching for these new targeted therapies, many of which work by blocking or counteracting interferon or downstream signaling in the skin. And the thing to remember is that early consistent treatment can prevent some of the devastating consequences of CLE flares like scarring and dyspigmentation in chronic cutaneous lupus. Now, I'm sure that you all know this, but lupus care comes down to teamwork, and your care team may include, or your lupus skincare team may include a dermatologist and a rheumatologist, especially if you have SLE, as well as you yourself and any caregivers you may have. And the dermatologists are tracking the skin clues, and the rheumatologists are monitoring internal organs, and the patients and caregivers are noticing patterns first. And keeping a photo log of your rashes and noting flares or new triggers can help your team fine-tune your treatment quickly. And having good communication between providers with you at the center is key for treating your skin lupus. Often dermatology is deferring to rheumatology in terms of selection of systemic agents or biologics, the medications that work from inside the body, because the internal organs, the threat to the internal organs can be more dangerous, but, it doesn't mean that we can forget about the skin treatment. And in terms of coping with visible disease, hair loss, scarring, and changes in skin color can affect confidence and emotional health. And it's important to recognize that some of the skin changes that result from cutaneous lupus are permanent, like scarring and some of the hair loss, but some of them aren't. And I find it helpful to discuss this with my patients and talk about what specific signs reflect ongoing lupus activity in the skin versus the damage that's already been done, because it helps patients know when and how to use their medications, like when a flare is starting up. And also brings us to a common understanding of what kind of improvement they could hope to see in their skin with the recommended treatments if they're successful. And then, of course, support groups and counseling and even cosmetic camouflage can help patients with CLE feel more comfortable in their skin. And the good news is that there are many treatments on the horizon. And so, we were talking about these sort of three main groups of key players earlier, but beyond these key players, there are many, many other cell types and signals that we are learning about that contribute to the development and persistence of lupus skin lesions. And the way that we're learning about these is through the kind of scientific research I've been discussing, where we're using mice and human cells and skin donated by patients with lupus to discover more about disease mechanisms. And figuring out these disease mechanisms points us toward new therapeutic targets. And thankfully, identifying these targets is already yielding new therapies that are changing patients' lives. And so I'm showing you the diagram here just so you can appreciate all of the new and emerging therapies in red here, each of which is considered a targeted therapy, which means they're medicines that are built to hit one very specific part of the immune system that contributes to inflammation. And this is different from many of the older treatments that are just like the sledgehammer to the whole immune system more broadly. These targeted therapies are precision tools rather than general shutdown, which can make them more effective and sometimes safer. And so some of these names you may recognize, like belimumab and anifrolumab, but many others are still in clinical trials. And that leads me back to what's next in skin lupus research. And while we have all these exciting emerging therapies that can help treat skin lupus, historically, many clinical trials have not specifically measured skin disease. And because of this, there are still no drugs besides hydroxychloroquine that are specifically approved by the American Food and Drug Administration to treat cutaneous lupus. And this means that dermatologists and rheumatologists treating patients with skin lupus don't always have the data they need to say whether a patient's skin will benefit from a new medication. And it can also make it harder to get insurance approval for medications in patients with isolated lupus of the skin because the treatments may only have approval for SLE. But fortunately, more recently, clinical trials for drugs like belimumab and Lista have started incorporating skin disease severity as a measured outcome. And this is largely thanks to the work of researchers like a dermatologist named Vicki Wirth from the University of Pennsylvania, who has worked to develop and validate and popularize standardized ways to measure lupus skin disease activity and damage. And in fact, now we're seeing trials like this one called the Lavender trial that our department is currently recruiting for at the University of Michigan, where the whole goal of the study is to see if the medication anifrolumab is safe and effective specifically for skin lupus. And we're enrolling patients with chronic cutaneous lupus and or SCLE whose skin disease is not adequately controlled by antimalarial therapies like hydroxychloroquine or who can't tolerate antimalarials. And I believe that they're also enrolling in Hamilton, Ontario, and planning to start enrolling in Toronto in the future based on the clinical trials website. But this is really exciting to see because the primary trial outcome that they're measuring is skin disease activity, and these are the kind of data we need to start getting specific approval for CLE from Health Canada and American Food and Drug Administration for these treatments. And with all these targeted treatments, we hope in coming years to unlock the promise of personalized medicine where we can understand a patient's specific lupus disease drivers and use therapies to target those precise abnormalities. And perhaps someday through these studies, we will achieve the holy grail, which is inducing an immune reset to cure skin lupus or systemic lupus or both. And in the meantime, we're still always trying to learn more about what triggers skin lupus. And one of the ways we're doing this is by looking at the difference between the sexes, because as you all know, lupus is much more common in women than men. And this question of why lupus preferentially affects women is actually one of the things I study in my own lab. And I came to this area of research through the work of one of my mentors, who's a dermatologist named Johan Gudjonsson. And he had discovered that a specific factor called VGLL3 was increased in the skin of healthy women compared to men at baseline. And he determined that this increased VGLL3 drives up expression of a lot of pro-inflammatory genes in the skin of women. So women are just walking around with their skin slightly more primed for inflammation and autoimmunity than men are. And when I joined Dr. Gudjonsson's research group, we engineered a mouse to mimic this state of having excess VGLL3 in the epidermis. And these mice developed scaly red discoid lupus-like lesions and dyspigmentation and scarring located mostly on their face, ears, and neck. So it was a pretty good model for CLE. But what was even more interesting was that the mice also developed evidence of systemic autoimmunity, like swollen lymph nodes and enlarged spleens and abnormal immune complexes in their kidneys. And they also accumulated autoantibodies like anti-double-stranded DNA antibody that's associated with SLE. So just by turning up the levels in the epidermis of this one gene that's higher in the skin of women than men, we can cause both skin and systemic lupus-like disease in mice. So this is another intriguing demonstration of the potential of skin inflammation to drive systemic disease. And we're still studying these mice to learn more about the mechanisms at play here and whether it's another pathway that we could someday harness to treat CLE. And then there's also the really exciting question of whether we might be able to prevent development of SLE. And one example of this that just came out is this exciting paper from a dermatology group from Tel Aviv University, where they studied hundreds of patients who presented to their clinic with a diagnosis of isolated cutaneous lupus, meaning they did not meet criteria for SLE. And the researchers followed these patients over time and found that those who happened to be treated with hydroxychloroquine had a decreased risk of developing SLE during the study compared to those who were treated only with topicals. And as for the patients treated with hydroxychloroquine who did end up progressing to SLE, they were also less likely to have severe SLE with involvement of internal organs than the patients who were treated with topicals. And you can tell I'm excited, and I have to temper my excitement because this is just one study, single center, patient population with limited racial and ethnic diversity. And we really need a large-scale randomized controlled trial to get proof of this. But these early findings suggest that treatment with hydroxychloroquine may be protective against progression to SLE of patients with isolated CLE. And there's actually been hints of this earlier in the literature. So one example is this 2007 study in the journal Lupus that was looking at military personnel with SLE or who developed SLE. So many members of the military are started on hydroxychloroquine Plaquenil to guard against contracting malaria during their service. So researchers compared those who took hydroxychloroquine to sort of matched similar patients who didn't, and found that those who had taken it ended up developing SLE later. And, this was in a general military population rather than patients with skin lupus. So it's sort of a different baseline population. But the evidence like this builds our confidence that we might be able to prevent evolution of systemic lupus by early intervention if we can find the right populations. Now, none of this progress in research and clinical trials would be at all possible without patient partnership. So like every skin biopsy, every blood sample, every survey from someone with cutaneous lupus helps us understand the disease better. The clinical trials are testing treatments that have the potential to change lives. And if you're interested, ask your doctor about registries or studies near you. And your in addition to accelerating science, your participation can help the next generation of patients. So if you remember only 3 things tonight, first, the skin offers powerful clues about the biology underlying lupus. Second, daily protection and teamwork can keep your disease quieter. And third, research is opening new doors for better, safer therapies. And patients like you have been and continue to be instrumental in that progress. And reliable information and having a community can make living with skin lupus more manageable. Lupus Ontario and Lupus Canada offer lupus education and peer support. The Lupus Foundation of America and Arthritis Society Canada provide online tools and advocacy, and as well as, of course, Lupus Ontario. And remember that you can ask your care team about practical resources like local programs for sun protective clothing or makeup recommendations. So skin lupus does matter, and you should not have to navigate it alone. And then I want to conclude by thanking you all for spending this time with me. And I want to acknowledge my collaborators and fellow lupus researchers who helped perform the science we discussed tonight, Kallenberg, Johnson, and we now work very closely with computational biologists. This is the one we work with, Alex Choi. And then our clinical research team, whose pictures I don't have here, but they are just as essential to our research because they inform our patients about the studies, including important parts of research like counseling them about the risks and benefits of participation. And then, of course, our lupus patients in the Michigan Lupus Program who have been so passionate about participating in our studies. And I'm grateful to Lupus Ontario for creating spaces like this where science and patient experience can come together. And I hope that tonight has deepened your understanding and given you some practical tools for living well with cutaneous lupus. And I'm happy to take your questions and hear about your experiences. Thank you.
Yeah, thanks, Dr. Billy. Please feel free to post your questions in the Q&A or the chat box. So we have received a few questions. I'll read it on Doctor. So first one is by Catherine. Is rosacea rash consistent with lupus?
Yeah, rosacea rash is a very complex mix of different presentations. Patients can have both rosacea and lupus, but they do not have the same underlying biology. Rosacea is a very, what we say, heterogeneous disease. So there are multiple different pathways that seem to lead to it. And because of that, many different treatments can be required before you can find the right one for your rosacea. Additionally, if you have cutaneous lupus and you have rosacea, topical steroids that can be used to treat cutaneous lupus can sometimes cause rosacea, either in predisposed patients who already had rosacea or in patients who had no rosacea before. So they can co-occur, but they're not the same disease.
Okay. The other question is red light therapy safe for lupus patients, particularly those sensitive to UV?
I would have to look closely at the information for that. I'm sorry, I don't know that off the top of my head, and I think you may want to check with the manufacturer of if they've tested it. It should be, but I don't know if red light therapy means it's exclusively red wavelength or if there might be other wavelengths included that could extend it to the ultraviolet spectrum.
So are LED therapy lamps safe for lupus? Do patients need to fully protect from the sun if CLE isn't active?
I believe that LED therapy lamps should be safe for lupus. In terms of fully protecting from the sun if CLE isn't active, there is always the risk that the sun can trigger your CLE. I very strongly recommend that all lupus patients protect their skin from the sun at all times. You have to balance this against living your life. And that's why, having a hat with a big brim in your car that you can grab every time you go somewhere, having these kinds of just easy, low intensity things in place that can help protect your skin goes a long way. But I would say it's important, and we can't still definitively say that your skin flare can trigger your systemic disease flare, but there's enough circumstantial evidence that I do think caution is warranted, and working to protect your skin from the sun and keeping your skin disease quiet could be beneficial for your overall health.
Okay. Can you have rosacea and CLE?
Yes, you can have both of those, and it can be a little difficult to treat both of those. As I was mentioning, topical steroids can sometimes flare rosacea. Depending on the type of rosacea that you have, there may be some other topical medications that could target both, or you could possibly use a combination of, that could target both. Maybe topical tacrolimus, topical calcineurin inhibitors that I was mentioning before, could theoretically be beneficial for both, or sometimes people will treat their lupus and then also add on another therapy to treat rosacea. Things that are common are topical metronidazole, that to my knowledge should be very safe for skin lupus.
Okay. So we have next question is, are anti-aging skincare products, example tretinoin, niacinamide, vitamin C, safe for lupus?
Those should be safe for lupus. Tretinoin actually sometimes it's from the family of medications called retinoids, which is, like I was mentioning before, Accutane. That's a systemic retinoid. Tretinoin is a topical retinoid, sort of in the same family as retinol, but a stronger sort of a prescription strength version of it. That kind of medication can actually be useful for overgrown lupus, like really thick discoid lupus, or sometimes what we call hypertrophic lupus. So it is compatible with lupus. And when used for anti-aging, thin layer all over the face once a night, it should be safe, especially if you don't have, active rash. If you do have active rash, tretinoin and other skincare products can sometimes be drying, and theoretically they could cause the little cracks in the skin, this impaired skin barrier that I was talking about, that could promote overgrowth of bacteria like Staph aureus. So I would be cautious if you're having a lupus flare that isn't, a thick discoid lupus flare where you've discussed with your doctor and have decided that tretinoin would be appropriate. If you're just having like a background lupus flare, like an SCLE or something, you might be cautious to avoid overdrying.
Okay. So the next question is, with lupus and seasonal allergies, my allergist has been treating my itchy skin with antihistamines, leukotriene, receptor antagonist, steroid topical creams, nasal spray, and also allergy shots. The only thing that has seemed to help has been the topical creams and the allergy shots. Is that likely? Because this should be reviewed by a dermatologist and is maybe outside an allergist scope. I am also on hydroxychloroquine.
Yeah, so certainly lupus and seasonal allergies can co-occur. I think it depends. If you're on Xolair, you may be having more hives type reaction rather than, for example, eczema, which can also sometimes go with seasonal allergies. And if you have multiple if you have a skin condition and a complex disease like lupus, I do think it's worth it for you to see a dermatologist at least once to get an evaluation and see if there is an underlying dermatitis or inflammation of the skin that would be treated in another way. Um, you know, Someone with lupus and a skin rash deserves to be evaluated by a dermatologist. Uh, Listening to that list of medications, I don't see anything that I'm concerned about, and they may all be individually benefiting you. It's possible that something could be more beneficial as well.
Okay. So the next one is, I was started on Safenal 6 months ago, in particular for my lupus skin flare, as well as other lupus symptoms, and the benefits has been life-changing. I'm so very thankful that this medication is helping calm my symptoms. Can you speak about whether you have seen more benefit to twice monthly subcutaneous versus monthly IV infusion?
The study that we're enrolling for now is subcutaneous. I actually very seldom prescribe it because most of the patients who we end up getting Safnello for, they need to have a diagnosis of SLE as well, in order to get it approved by insurance in America. And so often I end up referring to rheumatology and having them prescribe. We, though, have seen such good results with Safnello that at one point I proposed to Michelle Kallenberg, hey, we should do a study to look for, skin disease that's refractory to Safnello. And she said, where are we going to get the patients? Because so many of them have a great response. I'm thrilled to hear that you're doing well. And this is why it's exciting to be in science, because we are in the era where these pathways are finally yielding the treatments that can take advantage of that science.
The other question is, I have SLE for 47 years. I'm 82 years old. Can age be a cause for my skin problem worst? I take hydroxychloroquine.
So it depends if you're asking if age can contribute to skin problems in general, or if you're contributing, or if you're saying specifically skin lupus. The skin changes a lot as we age. There is, even in patients who have normal immune systems, there's something called immunosenescence, where the immune system changes over time and is sort of worse at ignoring the non-dangerous things and less effective at fighting the dangerous things. And, there are many patients who only develop eczema when they're older, for example. So you may, if you've noticed changes in your skin with aging, it may just be other non-lupus related aging skin, but again, a patient who has lupus and a rash or bad itching even deserves to be evaluated by a dermatologist at some point.
Okay. So we have this question, how can we treat or reverse hyperpigmentation and dark patches left from severe rashes?
Yeah, so it's tough, and the most important thing, which is easy for us to say, is just really strict sun protection, because the ongoing sun exposure can fix that darkness into the skin. So the inflammation that happens at the base of the epidermis, the attack on the epidermis, causes the pigment from the melanocytes, the melanosomes, to fall into the lower level of the skin and get gobbled up by sort of scavenger cells who then just sit there. So it takes a lot of time to move those cells out and have them turn over. And doing sun protection helps prevent further dyspigmentation or worsening of dyspigmentation. And then there are different medications that can be used topically to help resolve dyspigmentation. One over-the-counter, one that should be safe as long as your skin is not, really dry or affected by rash, is azelaic acid. And there are other over-the-counter things like kojic acid that can be beneficial. But if you have a lot of dyspigmentation, you can speak to a dermatologist and they may be able to offer you some prescription topicals. And then additionally, doing whatever you can to try to prevent future flares is very important. But it's hard when damage gets done, and these things just sometimes happen, and it's never the fault of a patient.
Okay. So the other question is what to do with lupus in the scalp.
Yeah, scalp lupus is difficult. Many of the things we use to treat lupus on other body sites work just as well. The scalp skin is thicker than the face skin, so we can use ultra potent topical steroids. You can do steroid injections into the skin. And then, some of these systemic agents that we've been talking about have efficacy in the scalp as well. But the scalp, especially discoid lupus, can result in really disfiguring hair loss, and it can be very stubborn. So going really, really hard on topicals and going quick to systemics, hydroxychloroquine and beyond, can be important.
Okay. So
And sorry, everyone. We're near the end of a presentation or end of our session, so we do have to wrap up the questionnaires. But for those who don't have the questions answers, we're gonna look into them and see if we could respond for you. We're just out of time tonight, unfortunately. But with that being said, I'd like to say a huge thank you to our speakers, both Dr. Wither and Dr. Billy, for their insightful presentations, and to our sponsor, Dr. Roche, for their continued support. We invite you to join us tomorrow from 7 to 9 p.m. for part 2 of our symposium. And just to stay connected, visit our website at lupusontario.org and follow us on YouTube, Facebook, LinkedIn, Spotify, and Instagram for more educational resources, upcoming events, and support programs. Thank you once more to everyone who's joined us tonight, and we wish you a wonderful evening. So thank you all.
Thank you.